Let's go. We're going to go live now.
Sorry.
Okay, guys. Stephen McInday from Perfect Balance Clinic. If you just joined us, this is our hour of power. So it's a time that we're going to help people regain their control of their health and management of their health and put their health back in their hands. So I'm joined today by Maud, our visceral specialist osteopath, who was with me last week, and the fabulous, the legend who is Dominic Alcock.
Hello, everybody.
Hello. So obviously I'm Steve and I work at Perfect Balance Clinic, and we've got a fantastic team of people who really inspire me. I think it's really great to see different levels of people coming through, from more experienced to more junior osteopaths and physios, and the team members coming through into the team. And I think it's great to get insight from everyone in their business, because I think sometimes if you're old and grey like me, you can miss things. However good you think you are, there's always things that people can show you. So I thought it'd be great to for Maud to get hands-on today, and for Dominic to join us as well, because he's got a real sporting background, which I think is really tied in with a lot of people with the particular condition that we're going to be talking about today. So today we're going to be talking about shoulder injuries and when your shoulder might not be causing a problem, and things to look out for when you're diagnosing shoulder problems. So Maud, tell us about yourself.
Hi everyone, so I'm Maud and I'm an osteopath. I've worked at Perfect Balance Clinic in Cambridge for a while now, and I just like to concentrate actually on something that's a little bit different, which is visceral osteopathy, which is actually working with the organs and trying to find the cause of the problem. Maybe somewhat different than the muscles and the joint, but somewhere in the viscera, somewhere like that. So I'm interested in working like that, and I'd love to give any advice if you need any.
Brilliant. And Dominic, what's your background? Because you're an osteopath, but you came into it from sports as well, didn't you?
Yeah, so I became an osteopath because of personal experience, really. I've had many different injuries myself through playing rugby, hockey and cricket before, including one injury that meant I had to stop playing most of those sports and had surgery on it quite a few times on my knee. I got into osteopathy because I was looking at alternative avenues to sort of go down to help people with musculoskeletal pain. That's how I came across it now, and I've got a particular interest in the treatment of sports injuries. But I like everything that comes through the door. General osteopathy, you would say, I think.
Brilliant. So we're joined by the big guns tonight. So you're going to get 3 top tips at the end. So if you stick around to the end of the show tonight, and we're going to leave you with 3 top tips. If you're struggling with shoulder pain, or if you play a sport that puts you at high risk of having shoulder problems, then Dominic and Maud are going to leave you with 3 top tips, or their top tips about what they're telling their clients to help them get the fantastic results that they're getting in the clinic as well. But so shoulder problems not always caused by trauma. So lots of different causes of shoulder pain, and one of the more unusual causes of shoulder pain kind of follows on from what we were talking about last week more, doesn't it? So there's not just shoulder pain, that we're talking about the left shoulder and how it could be related to your heart last week, isn't it? So that's a cause of shoulder pain as well. So just remind people how that works, Maud.
Exactly. So we talked a little bit about that last week, and that's about referral pain. Referral pain is basically pain that you're feeling in an area of your body, but that's not actually coming from this area, but coming from somewhere else. And in the example that we gave last week, it was a heart attack. So pain in your heart actually refers and goes to your left shoulder. And there's lots of different pains like that. So sometimes pain coming from your neck, but goes to your shoulders, or even down to your viscera. So even a liver or gallbladder, things like that, can actually refer up into the shoulders. So referral pain has something to do with the nerves. I don't know if you want me to try to explain a little bit about the mechanism.
Yeah, I think it's really good, because we touched on it last week a little bit, yeah. And I think because it's a new subject for people, when they first learn things that are new, it's quite useful to probably repeat it a few times, just so people can, if you missed last week, we can tag you into it on Facebook. If you just comment below in the box, and we can join you in on that. But yeah, Maud, so You've just done some like CPD, haven't you, on like pain and chronic pain? So yeah, tell us all about it.
Yeah, so basically, let's continue with the heart example then.
Yeah, sure.
So if you start having a heart attack, the nerve around your heart will fire lots of signal up to your brain. But your brain doesn't have many pain signals around the heart because it's not a common area to get pain. So your brain will get a bit confused by this strange signal coming up. So what it will do, it will send back signal down, but the signal will go in all of the nerve where the nerve coming. So basically, I'm getting confused. Basically, the heart goes into your, last time we drew it, it was quite nice.
Yeah.
Nerves around the heart comes into your spinal cord at a level of your spine. Once the nerve arrives there, it goes up into your brain. Once the brain gets the message, it sends down something to do, and the brain will send down a signal down to that segment of vertebra. And any nerve coming out of that vertebra segment will then fire pain signal. So if it's at a segment of nerve that going then into your shoulder, you will then feel pain in your shoulder because the nerve will be irritated and will send pain signals.
Yeah, that's exactly right. So the nerves to the heart are typically from T1 down to T5. And they also supply the sympathetic nerves that come up through the heart. So that's super important to remember, that it's mainly the autonomic nerves in this case that are carrying the pain signals. So we try and always give people a good idea of the difference between the different types of nerves, because Dom's going to talk a little bit about the nerves that actually move the shoulder, because they're completely different to the nerves that fire the pain signals into the shoulder, although they can be related as well. So it's just important to remember there's a bit of a difference between there. But not all pain arrives in your shoulder is from the organs inside, but there's a huge proportion of like problems that arrive in the clinic. Because remember, I think one thing that makes us a little bit different to other healthcare practitioners, especially in the type of clinic that we practice in, is that we tend to get the end stage of people's problems. So they've been to the GP, they've been to see other healthcare practitioners, they've tried medication, they don't really know what to do. So then they ring up the Perfect Balance Clinic. We sound like the A-Team or something, don't we? What's that program? How's the theme tune go? I've told the guys that come to the group DPD that I'm going to turn up with a little ISO cut with my B.A. Baracus haircut in one of the team sessions. But yeah, so anyway, people ring us up and they want answers on these really quite complex problems most of the time, actually. So I think if you guys found that quite interesting working in the clinic, it's not just like your bread and butter, people have fallen over, they've hurt their shoulder, they come in off the back of that. What kind of things do you think people come in with to the clinic?
But just for shoulder pain, just a massive range. You obviously do get the traumatic experiences where people have fallen on it
Yeah.
or had an injury, but quite a lot of the time it's when people have had it for years and years and years, and it's just been an ache or something that happens every now and then they've suddenly decided to do something about it. And
Yeah,
they're the ones that are quite challenging.
yeah, when they've had it for a long time.
Had it for a long, long time.
Yeah.
And they don't know why, they don't know what it is.
Yeah, see, those are the ones that I find really interesting, because the ones
definitely.
that they haven't fallen on their shoulder, they've not been catching balls or throwing cricket balls or playing tennis or anything like that, and they come in and they say, "Oh, I've been getting the general health issues," and then they don't really want to talk about the general health issues because they never think they're related. And then they say, "Oh, but my shoulder, it's really hurting in my shoulder." And you go into the history and you realize actually they've got these other things going on, which then you kind of piece together. So it's super important. Patients are aware that actually they should be telling physios, osteopaths, everything about their health, not just about the bit that's hurting, right? Because I think that certainly makes my job a lot more difficult in terms of trying to work out what's going on. So yeah, it's super important. Have you guys seen people where they've come in with shoulder problems and it's not been their shoulder that's been causing a problem?
Yeah, definitely. Because the shoulder itself is made up of 4 real joints, 3 true joints, and one other. So it could be either one of those joints. It could be coming from the neck. or from the back, or from the muscles that connect the shoulder blade to the back, or something like that. Even lower down, it could be down in a restriction in the muscle. Let's say I've got a right shoulder problem. It could be something that's actually on my left side or my left lower back that's not pulling its weight, and that's why I'm experiencing all that pain there.
I think you mentioned quite nicely that there's 4 joints that make up the shoulder, just because there's one of them that people always forget because it's not really a true joint, is it? But the main 3 joints are the ones that we normally like pin things down on, and maybe one of those is lesser common in terms of its kind of pain source, the sternoclavicular joint. But that's probably the most important joint in the body when you come holding the shoulder in place, right?
Absolutely. Well, yeah, because most people know that the shoulder's a ball and socket joint. So you've obviously got that bit there, which is your arm, your humerus bone going into that socket. You've then got another one pretty close to it, which connects your shoulder blade to your collarbone here. And then inside you've got the sternoclavicular joint, which is the only way of connecting via bone your whole of the arm to the center of your skeleton, the axial skeleton. So that's a really important joint. And then you mentioned the 4th one, which is the scapulothoracic joint, which is not a true joint. It's not bone on bone. There aren't ligaments. It's just connected via muscles, mainly the rhomboids and trapezius muscles and things like that, and the serratus muscles. Not the serratus muscles, actually. So any dysfunction in any of those muscles that connect and make up that joint can manifest itself in a number of ways around the other joints themselves. Yeah,
it's really interesting, isn't it? And as the joint ages and our posture changes as well, we find there's different stresses on the shoulder complex as a whole as well. So when you guys are looking at people with shoulder joint problems and they come in, they say, "Oh, I've fallen on my arm and I've hurt my shoulder," or "I've thrown something and my shoulder's hurting." Are there other areas that you guys look at as well that are not related so much to the shoulder? Well, related to the shoulder, but not the shoulder itself?
Absolutely. I mean, if somebody falls onto, you call it a foosh, don't you? A fall onto an outstretched hand. You've got to look at everything from the fingers to the hands to the wrist, because anything can go wrong there. Fracture of any bones in the wrist or anything like that, up to the elbow, all 4 of the joints that we've mentioned previously, and obviously the spine itself, the other shoulder, for example.
More, do you find there's other joints around the area that are related to the shoulder when you're treating people?
Yes, I think definitely the neck has a strong connection. Then you look lower down thoracic spine. Ribs as well, the rib cage and everything are very strong. That's also with posture. So I'm looking all around. So it's a little area, but it's connected to so much of your body that you're ending up looking very broadly and around the shoulder. So it's an interesting part of the body, I think.
Yeah, it's massively interesting. I think when you talk about the sporting shoulder as well, that's a real challenge, isn't it, to balance the functional aspects of the shoulder with regards to the physical demands of someone's sports with the shoulder as well. So it's a real challenging joint.
Yeah, really challenging joint.
You must have come across quite a lot of people with shoulder problems, because you're an ex-cricketer, aren't you, Dominic?
Not professional cricketer. I used to play lots of cricket. But yeah, shoulder problems are really, really common in cricket and all sorts of sports, because of the repetitive nature of bowling and cricket and throwing in cricket, and then other sports that are really heavy on the shoulders, things like swimming, rugby, American football, even football. Any sport you're using your shoulders. Some of the really common ones would be a rotator cuff problem, which is obviously really, really common. Should we talk about the rotator cuff a little bit?
Yeah, it's probably one of the most common things to go wrong in the shoulder, isn't it? This musculoskeletal. Yeah.
So because we can do all these funky movements with our shoulders, we can move them up and down over here and there, and we can twist it inwards and outwards. It sacrifices stability, so strength, for mobility, so we can move it lots, which means that the capsule of the joint and the tightness of the ligaments, the ligamentous structures that keep that joint into place, aren't quite as strong or as good as many other joints in the body if you compare it to the knee joint, for example. So the rotator cuff works really, really hard to keep the actual arm in place in the shoulder. It's made up of 4 muscles that come from the shoulder blade around the back down to the shoulder to the top of the arm.
Yeah.
And they're really, really important in all the movements of the shoulder. They contract to keep the arm in place, and they're very, very heavily involved. So if you have a problem with one of those rotator cuff muscles or any other muscle in the shoulder, quite often you find that all of them tighten up because they all have to work harder if one of them isn't pulling its weight.
Yeah.
And even problems that aren't actually directly a rotator cuff issue, sometimes a rotator cuff really, really has to work hard to keep the shoulder functioning. So it's a really, really common structure, not a structure, it's a group of structures. It's 4 separate muscles working really, really hard.
Yeah.
Supported by other muscles as well, but rotator cuff problems are really common in most sports people.
Yeah, it's really interesting. So Maud, so we talked about some of the more common problems that are associated with shoulder pain, but you treat people that have got more uncommon problems, don't you? Because you work mainly with visceral organs that can refer pain. So the problem's not in the shoulder, but it's been your brain thinks it's the shoulder that's causing the problem. So how do you go about assessing someone to make sure they don't have a problem with a rotator cuff problem and that it's more visceral? So what things are you looking for in the history when you go through a history taking?
So I would look at previous history. So I would look how they're using the shoulder. I would look at any sports that they're doing, and I'd look at any trauma that happened to the shoulder, if it's present or past, or at any point of their lifetime, if there's any trauma on the shoulder.
Yeah.
I look at how the presenting complaint comes about. So if it's pain on movement whilst moving the shoulders, or if actually it just comes on randomly at certain points of the day or during the night and things like that. So that's certain things that you can differentiate referral pain and trauma pain or muscle pain. So I would look at, there's an incredible amount of tests that you can do on the shoulder to work out which muscle is or which joint or muscle is involved with shoulder pain. So I would first look at any trauma and any musculoskeletal problems, try and figure out if that's what's causing the pain. And if I come at negative all of that, I then look a bit further and look at other potential causes causing the pain in the shoulder. So I'd look a bit further along, so on the spine, on the ribs, and then on the viscera as well.
Yeah, that's interesting. So are there particular, so I think there's quite a few people watching this at home, but if you were going to give someone advice around like dealing with their shoulder problem, obviously if they've got a problem where they've fallen over, they've hurt themselves throwing or catching or with a sport, then it's fairly obvious it's musculoskeletal. But there's the odd occasion where you had shoulder pain and it wasn't related to something that you did. What kind of advice might you give to someone if they were wondering like who they should go and see, whether it's just a normal osteopath or someone who's going to deal more with kind of assessing the visceral understanding, those kind of things? Sorry, not a normal osteopath, but a musculoskeletal osteopath.
Yeah, I mean, I think any musculoskeletal osteopath would do exactly the same test, and they would know as well if it's not coming from there. So they would know exactly, but which is interesting with when you're looking at people that works a bit more not only musculoskeletal, then they can actually help you further along. So they can actually help you to get the problem better. Because if you go see a musculoskeletal person and your problem is not musculoskeletal, you won't really get anywhere because it can only go to one point. I think always talk to someone that is a specialist into the field and has the answer for you, and then just explain everything. That's, as you were saying, patients sometimes don't explain everything or retract some information. So it's about explaining everything. Even if you don't think it's relevant, it might be relevant for the practitioner that's listening and that's trying to figure out what's happening with you.
Yeah. Dom, do you find that because you're a musculoskeletal osteopath that sometimes people maybe hold things back from you in the case history, and then like 3 or 4 sessions down the road, they say to you, "Oh, do you know what? This has been happening, and do you think it could be related?"
Yeah, well, quite often with musculoskeletal shoulder injuries, quite often there's a cause to it or something that's relatively obvious to people like us. But if there isn't, then you've got to look elsewhere. And then you've got to ask the questions about the function of their viscera and their organs. And if there's something that isn't quite adding up, then you've got to look further into it. Definitely.
Yeah.
I think past history as well.
Yeah, definitely.
Some people forget about a trauma that happened a few years ago, or surgery that they had done and things like that. And it's actually very relevant for us to know about that.
Yeah.
You know, we were talking about this in the team meeting today, actually, about like we were talking about energy, but that's a bit too much for this conversation. But past trauma, so not just physical trauma, but there's a lot of like emotional things that can happen with people in the past that can kind of lock in these pain patterns to people's issues that they're having as well. So we were talking briefly about, and it's probably something we'll expand on tomorrow in the team meeting, but how you've heard the phrase "what fires together wires together," haven't you? So let's say a simple example would be if I move my shoulder up and down and it's painful, because movement of my shoulder and pain come together and my brain will perceive both of them at the same time. One of the challenges that I can face as someone with a shoulder problem is that I'm moving my arm, and actually I then develop a fear of moving my shoulder because I know that it was painful at once upon a time, so then I stop moving it. So that's a very simple example. And I'm sure most of the people listening at home have had little fears and things creep in, but when those fears have not been resolved, so it may be that someone's had so I've this is an interesting one actually. So I had a lady who had a car crash, and her shoulder was damaged in the injury because she was holding on to the steering wheel, and shoulders were shunted back by the steering wheel, or her moving into the steering wheel. And we've sorted out most of the shoulder problem, and I thought it had gone. We'd scanned it. There's nothing major wrong with it. We'd worked on the soft tissues, got it moving. She had very good range of movement in her arm. And then something happened in the future which traumatized her emotionally again, and all of the shoulder problem came back again. And I thought, that's strange, isn't it? She's had no trauma, physical trauma. She's not fallen on her arm. She's not done this. So then we started to talk around the emotional aspect of what was going on. And actually, it turned out that it was a blue car that she hit. And I don't know how we drew the conclusion, but for some reason, the situation that she's been in had, like, there's something blue, the color blue was associated with it. And for some reason, her brain remembered blue and fear and trauma and pain and shoulder. And then as soon as she'd been traumatized with this blue, I think it was a blue spade or something at the beach, and someone had like gone to throw this blue spade at her, and she'd like got fearful of the spade, and she'd seen the blue, and her shoulder just locked up again. And she came straight back to see me again, and nothing had happened to her shoulder. So she hadn't even gone like this to protect herself or anything like that at all. And she got almost exactly the same symptoms back that she had even before we treated her. But this time when we approached it, we resolved it through, we sent her to a hypnotherapist actually to unlink those two memories together. So it was, fascinating. Yeah, it's very interesting. Have you had, what's your most interesting shoulder presentation you've had in clinic? You've probably both had a couple.
One that was nothing as interesting as that. Nothing that's I, for want of a better word, crazy, where you think you've got shoulder pain, but it's actually because of the car. But from a musculoskeletal point of view, was what one person really didn't understand why their shoulder was hurting so much, and it was actually coming from the opposite side of their lower back. All we needed to do was get that moving and get those muscles strengthened, and the shoulder pain completely went away. It's nothing like that, Stephen. But
that's a really interesting case. Really interesting. Sorry.
Pains or issues elsewhere can manifest themselves all over the place.
What made you go to the hip to try and understand what was happening with the hip there?
Just a standing exam. Absolutely nothing in the case history on this particular person made it sound like it was a shoulder problem. It didn't sound like it. And then I got to this individual standing up, and we looked at their shoulder motion. There's nothing wrong. Nothing was recreated doing it. And then I got, okay, fine. Look at the neck. Neck was fine. Upper back was moving okay, and then the lower back. And they just couldn't really move in one direction with the lower back. So we looked at that. And there was a couple of really tight muscles on the same side as that shoulder, and a couple that weren't really doing much on the other side. So it was not luck, I guess. It was just doing the tests for the shoulder that didn't really bear any fruit, because there's nothing really wrong with the shoulder. So you have to look elsewhere. It was pretty obvious when we started looking where we needed to.
Yeah, no, it's a fascinating thing, the body, isn't it? It's a fascinating thing. I think what's really interesting is that you maybe I'll draw it, because it's quite let's have a look, see what we can do. Maud likes my drawing, so she always some drawings on there from something else I was doing. See if I can get rid of those. My whiteboard's been playing up today, so I'm not really sure what's going on with that. There we go. Okay, so the way that I sometimes talk about it with patients, because it's quite a difficult thing, isn't it? Because patients come in and they say, "Oh, I've got this." What do they say to you? So they've got this pain here, and you're trying to explain to them that it's coming from their hip. But what's useful, I think, sometimes to explain to patients is that they're coming in with this pain, but that's just because things have got above a pain threshold. So most people understand that when you start to talk to them about it, and then they come in and you start to talk to them about these other things that have led up to that pain. So down here you might have, and they might not be so painful, but you might have your let's say you've got you had a bit of a car crash or something, and like you've had your hip stopped moving because you've like had a football injury, and you've got feet that are not working properly, and all these things that have mounted up over time. And your body's dealt with those, and those have gone away quite quickly. But then to fix that one shoulder problem, you've got to really try and unpick some of the other things that are going on. You may never fix any of these things completely down here, and that's probably if patients are complaining. I mean, this is probably a different subject really, but if patients are not complaining about something, do you think we should fix it?
I think if it contributes to what they complaining at that instance, I think yes.
I think if we see it as relevant or an avenue that we need to at least try to look down, then you've got to really. Otherwise, you're not giving the patient the best service you could be.
Yeah, the problem might come back afterwards if you leave some things around. So maybe sometimes it's good to go through the whole body.
Exactly.
Very, very interesting. So we've actually had a question come in from Graham, who says, "Hey, he loves the live subject, which is great. So thanks a lot for the feedback, Graham. It's great to have you online." So he said that you may have already discussed the tummy shoulder pain link. So he'll probably go back and watch the beginning later. But he often gets a fairly sharp pain in the front lower shoulder area after eating a big meal. And he's asking if you feel there's any link there, Maud.
It sounds pretty linked, especially because it's right after the meal. I'd like to know which shoulder, so if it's the right or the left. So for the right shoulder, it's often linked with the gallbladder or with the liver. So if it's something, it needs to know if it's a very fatty meal as well, and what food brings on the pain. Thinking of if it's a fatty meal, then you'll have the gallbladder working a bit more, because the gallbladder secretes some a kind of liquid that helps the fatty meal to come down more easily. So yeah, that's what I've been looking at. So it looks like it could be connected to viscera, just because it's so specific with when the person eats. But there's always so much more question that we will need to ask, and more things that we'll have to look at before giving a diagnosis. But yeah, I think that might be a potential thing to look at in that case.
So please don't laugh at my drawings, but this is just going to be a very quick schematic. So this is a body.
Snowman.
There you go. And these are going to be the shoulders over here. Let's have a look. You'll recognize it in a second, trust me. So if those are the shoulders, so it's just a really good way of remembering like where things are coming from, Graham. So what we tend to do when we're looking at someone, if that's we have an imaginary line, but there's a structure that runs across there called the diaphragm. So if this is let me draw it because it's going to be easier. This will be as you're looking at you, so this would be your right shoulder, and this would be your left shoulder. So the key things to watch out for here are obviously the big risks, aren't they? So someone coming in saying that they've got left shoulder pain. Now, what we've got to be careful of is that we start to open up the risk of telling Graham that there's potential serious things that are going on there as well. So Graham, if you're listening to this still, it's definitely worthwhile going to get that checked out just to make sure it isn't anything serious. But there's lots of things that could be going on around there with someone like that complaining of these issues. So, I mean, the key things are going to be to look at the organs. Now, we've said that the liver, which is over here, that tends to refer straight up into the shoulder there. And you've also got the gallbladder that sits under there. The pancreas goes mainly to the mid-back, doesn't it, when people get pancreatic problems, Maud?
Yeah, it goes actually over the front of the abdomen and mid-back. So it doesn't tend to go up to the shoulder. Yeah. So you've got this mid-back area pain. So that pancreas is going to refer back to the mid-back. So I'll draw the referral patterns on in a second. And then you've got other structures there. So you've got the spleen over this side as well. Oh. So the spleen sits under here, doesn't it? Under the diaphragm. But the big one for Graham, I'd be asking him questions about would be the stomach in particular, just purely because of the cardiac sphincter and the location of it. Wouldn't you say, Maud? Yeah, definitely.
So the stomach, which sits here, it's a bit of a strange shape. It's kind of like a J-shaped organ, isn't it? So with circles, you can't really get an idea of where that's going. But so stomach typically gives you kind of pain in this area and pain up towards the left shoulder. Would you agree?
Yeah.
Yeah, and obviously the organs can give people pain over the area. So Graham, it'd be interesting to see if you've got actual stomach pain as well, or if it's just in the shoulder itself. But that's definitely something to look at. One of the things that obviously is worrying is the heart also sits over this side as well, and that typically is the one that refers over to the shoulder there. So that's a red flag for us. So we'd want to warn you about that, but not worry you, but also go and get it checked out just to make sure it's nothing lingering there. So do you see many people with splenic problems at all?
Not that many, actually. I think that's one of the less common, I'd say, because spleen is a lot to do with lymphatic drainage. So it would be someone that has problems with the lymphatic system or overworking, all of that. So I haven't seen that many of that, but that tend to refer into the left shoulder as well.
Yeah, I'd agree with that. So left shoulder, and you get abdominal pain with splenic problems as well. So people come in complaining of like abdominal discomfort as well, and you palpate their spleen is often very enlarged as a result of the lymph nodes and lymphatic vessels being affected as well. But yeah, so any other questions just in the shoulder? And if I take a deep breath, it adds slightly to the pain. So that's very interesting. So I'll get rid of these in a second, but that's going to refer up to there. That's also going to refer up to there as well. So you can see there's no stomach discomfort. So we'd probably be, so he's got always after a big meal. Graham, have you had I don't know why I'm speaking to the phone. I should be speaking to here. It's almost like I'm talking to him over here. But Graham, so one thing would be really good to know is if you've been to see a GP or someone who's specialist in these things, to have a chat with them about it as well. But it's definitely worthwhile looking at. So the other thing that could be going on is do you see many people with hiatus hernias?
Yeah, a lot of people. That's very common.
Yeah.
Do you come across them, Dom?
Well, I was worried I had one once. I don't think I do.
Why's that?
Why was I worried about it?
Yeah.
Because I went through a period of having horrible pain in my tummy after eating, and I had quite a lot of acid reflux occasionally.
Yeah.
And I kept on hiccuping after eating and things like that, especially when I laid down on my back, and it wasn't very pleasant. And what I knew at the time led to that, but then it went away on its own. So it wasn't that. It was probably just a tight diaphragm or something.
Yeah. Out of interest, do you mind me asking you some questions about that, Dom?
Go for it.
Were you under any kind of stress at all at the time, or was anything else going on?
I was indeed.
Yeah. You don't have to say what it was, of course. But
I no problem with doing that. I was going through these thing called osteopath exams.
The most stressful thing on the planet.
In fourth year, my final year. And all that. It just went away on its own. I couldn't give you any more information because it was about a year ago now, and I can't really remember. Yeah,
no, it's very interesting. I think the diaphragm and stomach and the esophagus and the lower esophagus in particular, in terms of the gases and the acidic reflux that can happen as well. So heartburn. When you said you had the reflux, how did that feel to you when you had it?
It felt like almost a burning sensation just in the back of my mouth.
Right.
But that was really, really quite mild. Food tasted funny after eating.
Like a metallic taste or something in your mouth? Or,
yeah. Like again, that was only a couple of days, really.
Yeah.
And because of the people that I was talking to or friends with at the time, all I needed to do was sort of say it and say my symptoms, and people would work on my diaphragm and release the diaphragm, and that may well be why it got better, because it did get better pretty quickly. I never had it properly investigated. I never had it properly never had any consultation or anything.
Yeah, I think there's with people like that, with like Graham and yourself there, I think there's for me, I always want to know exactly what's causing the problem. If I can find out what's causing the problem, that helps me in my head, and then I can plan going forward. So I apply the same logic to dealing with my patients as well. So it's
100%.
Yeah, because it's just so much simpler, isn't it? When like someone like Graham, go and see the GP, go and get a thorough checkout, make sure there's nothing nasty going on first, then go and get some kind of assessment to look at. Probably a camera would be a good idea, just to make sure there's no esophageal sphincter problem, like a hiatus hernia or small. I'm not going to say any specific names here, but there's some conditions that affect the lower part of the esophagus where it can become burnt or damaged, and that can become very irritating, that kind of condition. So you really want to watch out for that and make sure that you're not missing something that's happening a lot. I mean, the big advice for Graham really is if it's big meals, try and cut down on your meal size, and try and just get a proper diagnosis and make sure you get a really good indicator of what's going on medically as well, because that's probably a bit outside of an osteopath role initially until the diagnosis come in. But once the diagnosis come in, then someone like Maud, you treat hiatus hernia, don't you, with visceral osteopathy?
Yeah, so you can't treat it as such because you can't really say that you're changing anything, but you treat in the sense you're treating anything that's around it and anything that can cause it to make it worse or cause any additional symptoms. So you would treat the diaphragm, you would treat as well viscerally, try to basically take out any other tension in the body that might add into this problem. So really trying to free out all of the area to help as best as we can that part. So
would you, I think, Dom, you probably noticed that, I wonder if this may not have occurred to you, but it probably does now looking back at the situation. But when you're stressed, the number one thing that gets affected is your breathing. So having poor respiration and giving people breathing exercise, or teaching them to relax, or like changing their posture when they're eating, perhaps for Graham, all of those things might have an influence on there. So like breathing exercises are often something you'd probably use alongside your treatment, right, Maud?
Yeah, a lot. I tell a lot of my patients breathing exercises. Diaphragm can cause a lot of tension through the whole body. So really using a diaphragmatic breathing can help with those kinds of problems, especially hiatus hernias and things like this, because the esophagus really passes within the diaphragm. So there's a hole where the esophagus just passes through. So if the diaphragm is really tight, it might just tighten the esophagus and so decrease the sphincter through there. So it's imperative to really release the diaphragm in these circumstances.
It's actually really interesting how this has gone sort of full circle, because I was working on the diaphragm with the person that I was talking about earlier with the shoulder pain, but the problem is actually on the lower back, because the diaphragm attaches to the lower back, to the actual spine itself. You've got to think about diaphragm and all lower back pain as well. And it was tight. It was tighter on one side than the other, the diaphragm. And we released that off as well, got it moving properly, breathing exercise. And that's how you treated the shoulder pain. So
yeah, I think that's I have this kind of tussle that goes on in my head all the time, because I'm very medical with the way I approach things, but also I'm very osteopathic with the way I approach things as well. And the two, I kind of have this balance. It kind of has to balance out, because you can't be too much one or the other. And I think it's like such a interesting thing, because you look at someone's body and you think, right, they've come in, they've got a shoulder pain. So as a medic, as a clinician, you look at that and you think, right, these are all the joints that are in the shoulder. This is what moves the shoulder. And you think about how they did it and everything else that goes on. But as an osteopath, it's so important to think about how the whole body works together and how the muscle, how that shoulder moves. But also, as I lift my arm up, as it gets higher, I have to bend my spine towards the side to be able to get the full range of movement. Just something simple like that. But not only am I bending to the side, I'm also expanding the rib cage on this side. So that's going to affect my lung here. It's going to squash the rib cage on this side. So the diaphragm is going to be inherently affected as well. So it's not just as simple as like just a shoulder problem and like opposite sides and stuff. There's this whole sling of like change that's going on in the body. And I'm not going to lift my arm up if I had some kind of like emotional trauma that's kind of hurt me when I've lifted my arm up or something in the past. So yeah, there's tons of stuff we need to think about. It's quite a complicated thing, isn't it?
Yeah,
quite a complicated thing.
Even if you do have a definite diagnosis of something that's going wrong with that joint. So if you tear the cartilage that is in between the ball and the socket of that joint, you can get that MRI scan, you can get 100% diagnosis, and you can treat the shoulder, strengthen all the shoulder muscles, the rotator cuff we spoke about earlier, and get the movement as good as it can be. But often you still need to look afar. So it's not just looking for what's causing the problem. Sometimes you have to look further afield to treat the problem, even though it's actually local to where the pain is.
Yeah, super interesting. Graham's actually said that it's always after a big meal, but not all the time. But he feels like there's some pressure there as well. So Graham's actually said his back's been great for 10 to 11 months, which is really good. It's been super, so it's really good. And he's going to pop in and see us after the lockdown, which is really nice of him. So Graham, try and just obviously cut down on the big meals. Make sure you go through breathing exercises, pop in and see us when you get a chance. But it's probably worth getting that checked out with the doctor just to make sure there's nothing else going on. And then you can like just relax about it. Hopefully we can sort it out when you pop in. But yeah, it's interesting. But yeah, I get what you're saying there, Dom. It really resonates with me that it's not just as simple as like looking at one body part and just thinking, right, that's what's causing the problem.
Yeah, definitely.
Yeah, very interesting. Great. We'll see you later, Graham. I'm still talking to the phone. I need to get out there. It's like he's here or something. Excellent. But yeah, good. So we should really wrap up there so we finish on time. But what would you say if people were coming in to see you with shoulder kind of problems? So where would you guys start with their shoulder problem if you were to give them like general advice?
General advice for a shoulder problem, and is your question?
If someone's fallen on their shoulder, maybe if you give them advice based on that, and Maud can give them advice based on like 3 things that she thinks are important if you didn't have any trauma with your shoulder, maybe.
Yeah. So function. So we want to keep it moving and we want to keep it strong, especially that rotator cuff and the surrounding muscles. So if you came in to see me and you fall on your shoulder and we've got a problem with the shoulder, we need to keep it really, really strong and stabilize it. So I'll give you some strengthening exercises, strengthen the rotation and all of the movements. We'll mobilize it. So stretch the neck, keep the whole spine moving, strengthen the shoulder, and don't eat large meals too often.
Yeah, good advice.
From earlier.
Excellent. Good. And Maud, what would you say your top 3 tips are for people at home if they've got undiagnosed shoulder problems?
So I think if it's not coming from any traumatic event, I think the main thing would be to really get it checked out to find the diagnosis and the cause of the pain. So your first line might be to see your GP. You can first come to an osteopath, and then we might then refer you to a GP if there's anything that we're concerned about. So if you want to come directly to us, that's fine. We might just refer you to the GP afterwards if there's anything that we're concerned about. It's not stressing about it because there's lots of different problems that can happen, and it's not always pathological. There's not always a scary problem. So it can be something very simple that we can work with. As we talked about a lot, breathing is a major thing that you can help your problem with. So breathing exercises, breathing through the tummy, really expanding the diaphragm and these lower ribs. And I say don't hesitate to come and see us, and don't hesitate to talk about a lot more than just your problem. So everything happening around it as well. I think that's very important.
I think that's the main thing for me as well. In the scenario that I was given, we said we've got a diagnosis, but the main thing is to find out what's causing it, because there is no general treatment. We can only treat what we think's going on, what we know is going on.
Yeah, it's a bit difficult to hit the target when you don't know where you're aiming, right?
Absolutely.
Yeah, it's very interesting. Good. Well, brilliant. Thank you so much both for coming on. It's been great. It's a pleasure having you on the Power Hour. So I looked up, did I tell you I looked up Hour of Power?
Yeah.
It was like we can't call it that basically because it was some like cult, so we can't call it that. So it's called Power Hour. Power Hour. Power. So anyway, it's been great having you both, and thank you so much for being such a great pleasure to work with. It's been great.
No,
so
thank you very much.
If you guys are listening, it's a pleasure. If you guys have been listening at home and you would love to get in touch with either Maud or Dominic, or you've got some more questions about your shoulder pain, you'd just like some advice, or maybe an online consultation, then just put your details in the chat box below and we will get back to you as soon as you put it there, and we'll get back in touch with you. It is pretty busy in clinic, but we will try and fit you in as soon as possible. Don't come in with too complex problems, but if we can help you, then we will certainly try to as best we can. But hopefully you guys are okay being locked in at home. We've got another 3 weeks of this, so it's going to be a long slog, but just to say that it's been great hearing some of the fantastic stories that are going on of people being inventive, ingenious in the clinic, outside the clinic, in the community. It's been really great to hear that. Did you hear about, is it Captain Tom?
15 million.
15 million. I mean, that's incredible. What a result that was. Hats off to him. Absolutely hats off to him. I was blown away by that. That's incredible.
Absolutely incredible. Yeah.
What an achievement. What a story to tell the grandkids.
Yeah.
Yeah, fantastic.
Absolutely
I think we
amazing.
should all bow down to him. What a fantastic thing. But yeah, if you've got any questions, you'd like some more input, then just get in touch with us. Graham's obviously going to come and see us. That's great. And Graham, look after yourself, mate. Lots of love to all the family and everything. I'll stop looking down there now because he's going to go. So yeah, it's been great seeing you. And don't forget, we've got an hour of power tomorrow evening. And tomorrow evening, we've got Rupert from Kitbag Coaching coming back to talk about the serve and all the things that can go wrong and also right. So you might get some tips as well. But join us tomorrow for the Power Hour with Perfect Balance Clinic. We'll see you later, guys. Take care. Bye.
Bye.
Bye-bye.